Good night, everyone. My name is Chi Chen. Today, I will talk about perfusion pressure. Perfusion pressure is one of the most important and intriguing idea in shock management. Understanding the perfusion pressure concept enables us to set up a goal for the blood pressure for every patient, and then to really optimize our organ blood flow by maximizing perfusion pressure. I will separate today's talk into three parts. The first part, I will talking about from physiology perspective, what are the pressure differences to drive organ blood flow. And then the second part is after understanding physiology, how can we maximize our organ blood flow by optimizing our perfusion pressure? Either you increase your MAP or either you decrease your tissue pressure. The last part, I will talk about, given the current literature, how do we set up a MAP goal for patients? Understanding that most patients can just have a MAP goal 65 to 70, but do we have some subgroup of patients that can benefit from higher MAP goal? Or do we have patients that just can tolerate a lower MAP goal? And I will talk about SEPSISPAM trial, and I will talk about a trial called MAP 60 trial that published in JAMA in February 2020. I will recommend you to read articles that published in Annal of Intensive Care in 2015 about personalizing blood pressure management in septic shock patients. And I will suggest you to listen to today's podcast first, after finish watching the video today, and then to read this article. And then you will have more sense about how to set up a MAP goal so that you can optimize your perfusion pressure for patients. First thing first, I will still remind everyone about the definition of shock. The shock is inadequate perfusion and oxygenation of cells that eventually lead to organ dysfunction and damage. Understand here we are talking about inadequate perfusions, not about inadequate blood pressure, not about inadequate arterial resistance, but perfusions. So as long as I have a good perfusion, I don't really care about the blood pressure, right? As long as the perfusion to the tissue are enough. So I always try to relate our physiologists to the physics. We all learn Ohm's law. The Ohm's law means that your electric current is basically your voltage over your electric resistance. And then you can use the same concept in blood flow. The blood flow is equal to the pressure gradient over your arterial resistance. And then I will talk about the pressure gradient in depth today. And then in the future lectures, I will talk about arterial resistance. And I would like to remind everyone the most important pictures about organ blood flow in this. You can basically using this graph to different organs and how their flow to pressure relationship. Understand that in the extreme conditions where you have a perfusion pressure too low or too high in the yellow curve, that your blood flow is pressure dependent. The lower the perfusion pressure is, the lower the blood flow. But during the normal condition, when you still have the preservation of your autoregulation in the organs, your organs try to maintain a constant blood flow by adjusting the resistance and the pressure of the organs and arterial supplies. And what we do as a critical care physician when we use vasopressors, what we do is literally to increase the blood pressure to a point that your patient's blood pressure and perfusion pressure is in the red zone. Means that you can allow the organs to preserve autoregulation to regulate the blood flow itself. And so the reason to use vasoactive agents again to increase MAP is to restore autoregulations so the organs can maintain the constant blood flow. Now, I always imagined before starting fellowship that the pressure gradient is very simple. It's basically there's an artery and there's a capillary and there's a vein. So the pressure gradient of the organ perfusion is there you have an inflow pressure from the artery and you have outflow pressure from the vein, and then minus each other you have a pressure gradient. Well, in reality, it doesn't necessarily right because there's a phenomenon called vascular waterfall. Um, so let me just skip to explain that. Let me just give you a few explanation by giving you the graph of cardiac output to arterial pressure. We know that arterial pressure is proportional to cardiac output, but it's an interesting thing to see that when your cardiac output come to zero, your arterial pressure is not necessarily zero. That means that you don't need arterial pressure to be zero, and then at a certain extent, your artery will just collapse even when the arterial pressure is not zero. Because your artery is collapsed, so your cardiac output falls to zero. So there's a thing called critical closing pressures. This is a graph of an arteriolus. Arteriolus is surrounded by the smooth muscle, and smooth muscle is being regulated by the sympathetic nerve. And with all the things together, you have a certain arterial tone. Then the definition of critical closing pressure is the pressure where you basically lost your arterial tones, and then your arteriolus collapse, and because arteriolus collapse, your blood flow cease. And this critical closing pressure is basically regulated by different things, but most prominent factor is the sympathetic nerve. When you have a sympathetic nerve stimulations, you have critical closing pressure goes higher to 60. And when you don't have a sympathetic tone, let's say you are using the alpha blockers, so you lose your arteriovascular tone, so your critical closing pressure goes lower. Normally, human beings depends on the different organs, depends on different atherosclerosis process or different sympathetic nerve status. But your critical closing pressure is around 30 to 40, and most of the time is higher than your CVP or your tissue pressures. So what really means the vascular waterfall is what really drives the pressure difference for the organ blood flow in normal condition is MAP minus your closing pressures. This pressure difference is the driving force for the organ blood flow. It doesn't really matter in the normal condition about your CVP or your tissue pressures. Or the driving force is from the MAP minus your closing pressures. So you can see as here, the curve shows you have a difference of your pressure drops along the vascular tree. And pressure drop from the MAP and closing pressure is the driving force of your organ blood flow in normal conditions. However, so first let me summarize. So what a pressure difference drive organ blood flow during resting condition when you have a preserve of autoregulations is MAP minus your closing pressure. But when you encounter profound hypotension, basically you lose all the autoregulation, then your calculation will become MAP minus your tissue or CVP pressure. Well, most critically ill patients are hypotensive. So when you become hypotensive, you lose all the autoregulation in organs. Your sympathetic tone is not able to maintain your artery tone. And then your organ perfusion then will depend on the perfusion pressures. So it's important to understand that during the initial resuscitation, when you have patient become really hypotensive, that thinking about the perfusion pressure and try to increase that so your organ can restore the autoregulations. In the different organs, your perfusion pressure is kind of like slightly different. In brain, it's MAP minus intracranial pressure. In the abdomen, let's say your kidney or your liver or your gut is MAP minus your intra-abdominal pressures. In the heart, it's a little bit different because the left coronary artery mostly perfused during the diastolic phase. So the coronary perfusion of the left coronary artery is diastolic pressure minus your LVEDP. And I would like to dig deeper into the individual organs and talk about the things that I feel that important. In the brain, the cerebral perfusion pressure, the goal should be 60 to 70, and is mostly derived from the literature from traumatic brain injury. We know that if you have a low perfusion pressure, it's not good for the brain. But mainly just using the vasoactive agents to increase the perfusion pressure more than 70 also carry the worst outcome because you have likely to cause cerebral edema. And so I think the goal for cerebral perfusion pressure nowadays kind of like in the sweet spot 60 to 70. On the same time, you want to do things to reduce the intracranial pressure because you know that patient with the intracranial bleed or massive stroke, you have a mass effect. And you have to think about those things when you have an ICP monitor that's showing the high ICP, and you want to do those things to lower the intracranial pressure. We'll talk more when we talk about neurocritical care. The other things I want to bring out to your attention is that your autoregulation curve will shift to the right in patient with chronic hypertension. That means for patient with chronic hypertension, your MAP goal may be require a little bit higher because your autoregulation curve shift to the right, and you may require higher MAP in order to make sure that your perfusion pressure is in this flat curve region. Okay, let's talk about the kidney. The autoregulation for the renal perfusion pressure usually is between 60 to 100. And there are a lot of interest in digging into whether when we using a higher MAP goal, and can that increase the renal perfusion pressure and increase the renal blood flow? And I think the literature is kind of constant saying that if you have some patients with chronic hypertension or a patient with renal vascular disease, it may be reasonable just increase your renal perfusion pressure to increase your MAP pressure to 70 to 85, and that can potentially improve renal blood flow. If you increase the MAP more than 85, there's no benefit, but just causing more risk for tachyarrhythmia. And in 2017, Dr. Pauls wrote, basically summarized all the literatures from like 1987, I think, to now, to see whether increasing MAP using a higher MAP goal can increase renal blood flow and lower the risk for acute kidney injury. And it's basically just what I said is the MAP 70 to 85 is a reasonable option. If you have a patient that really doesn't make any urine with a MAP of 65, you can just try that and to see if a patient make urine after you increase the MAP. And I just want to spend like 2 minutes to talk about the current concept that I feel very that have a lot of interest in, is using the Doppler as a way to measure the blood flow to the organs, as a way to resuscitate a patient. You know, we always try to resuscitate a patient, try to understand what's the cardiac output being, and what's the CVP or what's wedge pressure and all that, or what's the fluid responsive of the patient. But as a matter of fact, the reason we want to know that is to try to make sure the patient's blood flow to the organs are sufficient. What if we don't care about the cardiac output? We don't care about the stroke volume. We just care about the blood flow to the organs by measuring the blood flow from the Doppler in real time. So let's say take the kidney for example. There's a thing called renal resistivity index. Basically, you put a pulse wave Doppler in a renal artery, and then you can measure a systolic and diastolic velocity. So you can see from here that in the pulse wave Doppler, there's a systolic peak and there's an diastolic velocity. By calculating the renal resistivity index, you can see whether the patient is having an adequate renal perfusions. Resistivity index more than 80% just means that you have a high risk for progression of your kidney injury. And so let's say if I have a baseline and I give a 1 liter of fluid and I measure again to see if the renal blood flow, renal resistivity index improve. And that's a kind of intriguing idea that in the future, maybe we have more options for just measuring the renal blood flow, just measuring the liver porta hepatis flow, just measuring the carotid Doppler. And as long as those flow are adequate, I really don't care about the cardiac output. And I care about just whether there's a sufficiency of the blood flow to organs. Okay, talking about the heart, so the left coronary artery perfusion pressure is around 50 to 75, and the calculation is from diastolic pressure minus your LVEDP. And really not about the real number, but I want to bring out the concept about you have a patient with acute ischemia of the heart. Let's say you have acute coronary syndromes. Without cardiogenic shock, the reason for dropping the heart rate is not only decreased cardiac demand, but because you drop the heart rate, you have more diastolic phase. When you have more diastolic phase, you basically have more time for the coronary artery to perfuse because coronary artery only perfuse during the diastolic phase, right? Um, the other thing that important to this coronary perfusion pressure is that if for patients that to gain the ROSC during cardiac arrest, you need the coronary artery perfusion pressure to be 20 to 25. If you stop your chest compression just like maybe 3 beats, and you have a significant drop of your coronary perfusion pressure, and it requires 3 to 5 beats in order for the coronary perfusion pressure to raise to 20 to 25. So that means that during CPR, we want to minimize the time for chest compression interruption. The last thing I want to talk about is that if you have a patient with LVH, it's very obviously that your autoregulation curve will shift to the higher level. So in those patients, you may require higher MAP in order to achieve a well perfusion pressure. Okay, the last part I want to talk about 2 trials, SEPSISPAM trial and MAP60 trial. So do we really have evidence for setting a MAP goal 65 for patients in sepsis? There is a randomized control trial compare high and low blood pressure target in patients with septic shock. So for patients with septic shock, it's divided into 2 groups. Higher MAP goal, 80 to 85, or lower MAP goal, 65 to 70. They want to see the primary outcome get affected or not, is mortality at 28 days and mortality at 90 days. So you can see that in the trial, you can clearly see there is a difference of the blood pressure curve in the high target group and low target group. But I would like to ask you to pay attention to the low target group. You see that even you set up a map of 65 to 70 as your goal, in reality, most patients in the low target group have a map 70 to 75. And that is because, as you know, the nurse is titrating the vasopressors, and maybe sometimes they are afraid that map goes too low. So if you see a map of 66, they will just increase your vasopressors. So it ends up that most patients in the low target group have a map 70 to 75. And then looking at the outcome, you can see that I know the words may be a little bit small, but I will guide you through it. So the primary outcome in the death at 28 days, there's no difference in the low target group and high target group. So that's why we say that most patients can have a MAP goal of 65 to 70. But I understand that in this trial, most patients in the low target group have a MAP of 70 to 75. And it's very interesting to see in the pre-specified subgroup that in patients with chronic hypertension, you can see that maybe they will benefit from higher MAP goal because they have less risk for going to renal replacement therapy. The number to treat is around 10. So in patients with chronic hypertension, maybe it's reasonable if they don't develop tachyarrhythmia with higher MAP, higher vasopressors, just keep the MAP a little bit higher so they have a better renal blood flow. And then you can reduce the need for hemodialysis. Lastly, it's not surprising to see that patients with a high target group have a higher risk of atrial fibrillation just because you are using more vasopressors. Okay, another trial that published this year I feel that is very interesting is MAP60 trial. So basically, they want to entertain the idea of permissive hypotension. We know there are some elderly populations that they just have a lower vascular tone. They live at higher MAP at the baseline. So do we really have to maintain everybody of MAP 65? Or can we just keep some patients without organ dysfunction and they leave a MAP 60 happily, just keep the MAP at 60? So basically, it include the patients that with age 65 or older, and if they require vasopressor for 6 hours. In the permissive hypotension group, they keep a MAP goal of 60 to 65, And then for the control group, they just using the usual care for physician discretion. They don't have a set MAP goal. And the primary outcome is 90-day mortality. As you can see in the trial, there is a separation of the two groups in terms of a MAP goal, in terms of the MAP that the patient have. But again, I would like to ask you to pay attention. The first thing is in the permissive hypotension group, you still have a lot of patients that MAP is 65 to 70. And then definitely in the patient with the control group, you do have a lot of patients with a MAP of 70 to 75. So that is again an example of you have a goal for in the trial, but in the reality, then the MAP goal from the patient is different from the trial that you design. And as you can see here, in the Kaplan-Meier survival curve, there's no mortality difference between these two groups. And also, I didn't include in my slide is there's really also no difference in the need for hemodialysis. So the conclusion of this trial is that for older population, it may be reasonable to keep a patient with a MAP of 60. And so what I will say is to be cautious for reading this article is because for patients, I would say it's reasonable to set up a MAP of 65. But for some folks, if you have a patient that just constantly require a little bit of pressures to keep a MAP 65, it's reasonable to keep a MAP of 60. Okay, so let me review the key point of this talk. Is first I talk about the pressure difference in driving the organ blood flow, and talking about the vascular waterfall and what is the critical closing pressure. In patient lose of autoregulations, and it's really important that at that time your organ blood flow become pressure dependent, and it's important to maximize the perfusion pressure by increasing your MAP. At the same time, you decrease your tissue pressure. The last part is we talk about the MAP goal for most patients. It's reasonable to set up a MAP of 65 to 70 in patients with sepsis, but for a subgroup of patients with chronic hypertension or renal vascular disease, it's okay to try to keep a patient at MAP goal of 70 to 85 in order to improve the renal blood flow. Okay, so that is my talk for today. During the next talk, I will talk about vasopressors, how we use vasopressors, and how we titrate the vasopressors. Let's say if you have a patient with norepinephrine on a higher dose, what are the second choice? When we use vasopressings, what's the rationale of using that? And then if you want to add epinephrine, do we have any alternative options for doing that? And what's the rationale for step-up therapy? So that will be the talk for next time. Thank you everyone for paying attention. And if you have any advice for my talk, you can leave a message in the YouTube videos.